There's no doubt that we are really witnessing a rebirth of cancer immunotherapy. Now we have new tools that can activate the immune system against cancer, and we're witnessing important responses to immunotherapy in tumors, not just melanoma, which was considered to be a cancer type that responds to immunotherapy, but also in other solid tumors that traditionally have not responded. For example, lung cancer, that was the major revelation in the last 2 to 3 years. We now understand that there is an immune response that can be activated very effectively with new antibodies that block inhibitor receptors on T cells. There are many innovations that are presently brought to bear in the field of cancer immunotherapy. Largely, I would think there are two new classes of interventions. One is the antibodies that target specific receptors that inhibit or regulate the function of lymphocytes. So these antibodies are given therapeutically with the purpose to activate T lymphocytes against cancer. They rely on the presence of an endogenous immune response against tumor. We now know that there are such responses in the majority of patients with solid tumors, and these antibodies engage those responses and activate them. In many patients, we do see objective responses following treatment. Another class of intervention, or class of drugs, is actually cell-based therapeutics, where now autologous T cells are generated to fight cancer, and these can be either harvested from tumors, such as it has happened in melanoma, for example, where endogenous T cells are removed from tumors, expanded, and readministered to patients, or in a more commonly used approach today is T cells that are engineered outside of the body with new receptors that enable them to recognize tumors. And these are now used very successfully with great promise in hematologic malignancies, lymphoma, leukemia, but also solid tumors such as melanoma, of course, but also synovial sarcoma, ovarian cancer, I think this is a growing list of opportunities that are about to come to the clinic. Some of these classes of molecules have already been approved. Ipilimumab has already been approved for melanoma, and I think there will be opportunities to use ipilimumab in other solid tumors with great promise. Other antibodies in the same class of drugs are coming right along, and I think we should expect approval of some of these within the next year or two. The adoptive immunotherapy is in developmental stage, but I wouldn't be surprised if some of these approaches are also approved within the next 2 years. Regarding the biomarker identification, we're still quite early, I would think, in the game. You know, there is still a lot of work going on with large gene expression profiling, large efforts at immunophenotyping, the peripheral blood cells or the tumor microenvironment. So we're quite early, and we don't have really robust markers that will allow us to select patients at this point.